Hi friends, this is Dr. Sanjeev from Patna, India, and you are going to see a case of tympanoplasty. Actually, tympanoplasty is the most common surgery across the world in ENT. So we need to know how we do that and what could be the best way of doing tympanoplasty. For me, it is a totally endoscopic approach, transcanal endoscopic approach for last 14 years, and it is about 2000 tympanoplasty we have completed till now with this approach. So it is not a step by step principle of surgery is same, but the approach is different. You can visualize very well that fastening of margin with a curved needle and with micro seizure, we are just removing the tag, and it is a perfect blend of using a very sharp instrument, a stable hand, and with one hand is endoscope, and I use always 4 mm telescope, which is used for nasal surgery, that is a common telescope. And now my most favorite technique of doing tympanoplasty is a double dot flap technique. What is double dot flap technique? Let me show you this whole process, unedited, minimum edited video of this surgery. And we have taken incision from 12 o'clock to 6 o'clock in anterior canal wall. It is almost 5 to 6 mm, approx 5 mm lateral to the bony annulus. So this could be the flap size, and it is a big flap. Bigger flap will give a mechanical advantage of doing endoscopic tympanoplasty, and this cottonoid wall is again we are using for a hemostasis as well as the mechanical advantage. Now with the this anterior recess is deep here, so we are using a 70-degree rosin knife to elevate the flap till the annulus. And ultimate goal of doing tympanoplasty is to elevate the fibrous annulus and give a cut over the mucosal layer of tympanic membrane. What we are aiming this by this way. So with a flag knife, just we are trying to just dislodge the fibrous annulus from the bony annulus, and this is what we have done. Even in deep recess, there is no need of canaloplasty. If anything, best in transcanal, it is an endoscope I always emphasize in my surgery. So with use of Adeline saw cottonoid wall, we are just trying to achieve the hemostasis as well as getting mechanical advantage by using this cottonoid ball. And with sickle knife, we are just cutting the mucosa of the tympanic membrane residual and thus creating anterior door, big anterior door. This gateway to the middle pro-tympanum is a very good to see. The pro-tympanum is healthy, whether there is any disease situation is there. So this now we are taking posterior incision, that is far lateral from the anterior one in posterior canal wall, over posterior canal wall, and it is 1 to 2 mm lateral to the anterior incision. So by taking this incision, we always try to avoid full cuff elevation of tympanomeatal flap, that is the skin of the canal. A skin is the best dressing material in the body. So we need to preserve this skin with a vascular, like a vascular flap. So we are just elevating that posterior tympanomeatal flap, and we will use again the cottonoid ball stock in Adeline just to get hemostasis as well as the mechanical advantage. So with again 70 degrees Rosen knife, we are trying to elevate the fibrous annulus. And here is a caution, just try to identify the chorda tympani first. And we can visualize the chorda tympani by this way. So again with a sickle knife, we will cut the the mucosal layer, and then we will see you the entire posterior. We will show you the entire posterior door, and this posterior door is going to merge with the inferior portion of the anterior door, so that 360 elevation of fibrous annulus could be achieved. And with this elevation, we can see the entire bony annulus can be visualized inferiorly. And this is what we are just elevating the flap up to the neck of malleus. And this is irrigation of isthmus, very essential in my routine tympanoplasty, because this is the denominator of doing cat approach. If this is not pass, it means there is a resistance in irrigation. It means there is a blockage at additus level. So this is pass in this case, and this is a simple type 1 tympanoplasty. We can visualize very well the oscular assembly is intact. We have created the posterior door, wide anterior door you have seen. So with this posterior door, we are placing the graft. Graft is going to go inside the mesotympanum, and this is underlay. Underlay means under the handle of malleus. And this is type 1 simply, so we just do underlay. Otherwise it could be fish out technique, it could be denuation of malleus and then overlay. Many things we can do with this double door flap technique. And abscess is very important to put inside the mesotympanum. As you know, we have again emphasizing that this abscess inside the mesotympanum and in the canal after placing the graft is just to stabilize the graft material and tympanomeatal flap and give adequate pressure in between these two, the fibrous annulus and residual tympanic membrane with the graft, just to vascularize early. This is basic concept of putting abscess inside the mesotympanum. And it has been a very 14 years of this putting abscess inside the major, and nothing will going adversely in my almost all cases. If you preserve the mucosa of the mesotympanum, certainly it is not going to get any fibrous band because of this abscess inside the mesotympanum. So with the anterior door, just I am taking out the margins of graft just to arrange properly across the 360 bony external canal. And this is abscess. You can see we need more abscess to avoid anterosuperior gap between the residual tympanic membrane and the neograft. So this is how we do our routine tympanoplasty, and this is almost a very common operation across the globe. And it is, for me, it is 100% endoscopic, transcanal endoscopic approach. And this is how a skin to a skin closure of the canal. As you know, a canal skin is very, very important for healing, and it could be a very well arranged, no undue folding, no unwanted folding of this tympanomeatal flap and graft is required. So here we have almost placed the graft. Now it is said that the anterior blunting could cause some hearing loss, but I haven't agreed in my observation for many cases. But still we need to reinforce this anterior recess with a compress abscess, rectangular abscess. Although if it is the fibrous annulus is intact, then it is going to sit uh, as near to the bony annulus because of his strength of the fibrous annulus, if it is not broken at all. So this could be the reinforcing enforcement of the anterior recess to avoid the anterior blunting, as well as stabilizing the tympanomeatal flap, and it could be the firm adherent between the neograft and the canal as a canal of the bone of the external canal, anterior and posterior with the tympanomeatal flaps. These are the functions of abgel inside the middle ear and in the canal. Especially we are using a dry rectangular compressed abgel because of creating pressure after giving some medicated abgel after that. So this is what we use the 4 mm endoscope, telescope, and few instrument. As you have seen in this video, that is the curved needle, sickle knife, rosin knife, and flag knife, and macro scissor, and crocodile forceps. No special instrument is required in doing transcanal endoscopic tympanoplasty. It is not the holder, it is not the double-handed, it's like nothing is required. We have done with this routine regular single-handed approach with a dynamic endoscopic situation. It is not like a fix with endo holder. So this is my routine endoscopic type 1 tympanoplasty. Hope you understand very well. If any questions regarding this tympanoplasty, we will be happy to answer all these questions in my comment box. And please do watch this video, like this video, and share this video. Thank you very much. Thank you very much for watching again and again and supporting me. Thank you very much.